yeah, so I have been a dentist for about 22 years now, and came to the UK straight after getting my degree in South Africa. So hence the accent. Live up the road in Guildford, and have been through a long dental journey. After my initial degree, got a master's degree in America at NYU, um, in cosmetic dentistry. But I'm going to use my iPad. I'm going to sit down if you guys don't mind. I'm going to show you a few pictures. Pictures are just actually for me to keep my train of thought, and then afterwards I can share a lot more images and information with you guys. So please, afterwards, um, share your numbers, your emails, and your LinkedIn profiles, everything with me, that we can connect and hopefully work together. It's Dave has been the first physio that I've worked with. In all clinicians, we work with each other quite a lot, and it's been very fruitful because I think in dentistry, especially, there's been for a very long time there's been a disconnect between the dental field and the rest of the body, basically, and as we know, it's all connected. So yeah, let me start. If you guys want to stop me at any time or ask questions, don't worry, it's not. I haven't prepared a lecture or anything like that. So if you want to stop and ask questions or add anything, please do. Um, I'm I'm used to winging it, so and that's exactly the same today. Um, all right. Dave, is this thing on? Do you want? Yeah, is it on? Is it making a difference? Yeah, yeah. All right. Place that there for a second. I had to clean my iPad screen because all these touchscreen things. You think you're just using it as a computer, and still you try to actually look into the screen properly, and then see all the finger marks. All right. So I'll just hold it like this. This is me most Saturdays. As you can see, most of you will know this area. This is Newlands Corner on a Saturday morning. This was during lockdown. You'll never ever see it like that because there are always millions of people around their dogs and people running around. So I actually found out during lockdown that I enjoy cycling much more on my own than I do with my mates because they all keep talking nonsense all the time. So, but still, every weekend cycling, love sport. This is me and my family a couple of weeks ago in Belgium at Spa at the Formula One. And if you don't find me exercising most of the time, I love live sports, and the family as well. This is the Formula One. This is from the top of Eau Rouge, all the thousands of Max Verstappen fans, and everything live sport just intrigues me, and that over the years has brought me into treating a lot of sports people as well, especially in Weybridge. There are a lot of sport clubs, a lot of celebrity sports people, a lot of Chelsea players. There's a lot of Formula One guys that become my patients, and probably just because of the love of sports, they send their friends and family. There's another picture of me and my son playing golf, my other passion. Luckily, I told John earlier that it's raining now, so usually on a Friday afternoon I'll be playing golf. But I decided to spend it with you guys. Right, Rugby World Cup in Japan. Another one in Japan, live sport. Met this guy, and actually he's one of the Japanese mascots, and ended up treating him back in the UK a couple of weeks ago for facial pain. Most of the things that I do now is not to do with any muscle disorders or treating pain or anything like that. Most of the time, I'm trained as a cosmetic dentist, which has evolved into full restorative procedures, mainly with reconstructive implant surgery, crowns, veneers, and things like that. All these photos that I might show of patients are all consented. Big word in all our industries. Okay, so teacher at my son's school, during lockdown, she had to do a lot of video conferencing, video teaching for all the kids, and in the screen like this, she saw her own smile and her own teeth, and she was devastated because normally she doesn't look at herself, but during lockdown she had to, and she came to me and we fixed her teeth. It probably took about a year. This was an intraoral photo of what her teeth were, a lot of broken teeth, a lot of pain, and a loss of self-esteem. And for a teacher, especially with kids, that can be very cruel. It wasn't great for her. Right, so a little bit of the technical stuff, and I can show you lots of pictures. This is her upper jaw just upside down, a few implants placed, and then individual crowns on an implant bridge. Right, so we eventually placed this in her mouth, and that was a smile afterwards, directly after placement. And she turned from being a 50-year-old, turning 70, feeling old and afraid, into someone that could smile from the side and from the side. Right, there's the implant bridge in place. Each individual tooth was created with me in the lab that we've got on site, and it's just life transformation. All right, but that's not what we hear about today. When I first started the journey in cosmetic dentistry, I was qualified about 3 years, 2003-04. I got involved with an American group that was pioneering cosmetic dentistry in the UK, because in the late 90s, early 2000s, cosmetic dentistry wasn't really something that people were talking about or were even interested about in the UK, and there was a big market for it. I ended up signing up for a 2-year master's degree course at NYU that was going to do part-time, and the day that I signed and paid my deposit, my wife told me she was pregnant. So, long story short, a couple of tough years, flying backwards and forwards once a month for about 6-7 days to New York and Miami as well to do my learning on site, because obviously all these things are hands-on. Came out the other side with the masters from NYU. But the first weekend that I sat there in the lecture hall was very, very heavy on my heart, because I had a patient that I treated basically from day one when I arrived in England. I treated her for 3 years. She had a lot of pain, she had a lot of toothache, she had lots of trouble with teeth. I did multiple root canals on her. I took out 3 or 4 molars, and it never relieved the pain. And everything I learned at university and everything that I shared with other dental colleagues, we couldn't get her out of pain. We obviously kept trying to help her. She was referred to hospital, firstly to the oral maxillofacial department, and she ended up at neurology and then at neurosurgery. And on the day before I left for my first trip to New York, she said she had an appointment to have some brain surgery, and they were going to, she had pain in her face, in the trigeminal area, and after everything and all the unnecessary root canals that I've done and the teeth that I've taken out, you know, not by being negligent, but by trying to help her, after all those things, an MRI, they found that a little foramen in her skull, where the nerve is coming through, is constricted, and that nerve will have to be opened, or the foramen has to be opened to release the nerve, and that will relieve her pain. But as we all know, the the trigeminal nerve, that is the ganglion in the brain where the three arches comes out in the foramen at the base of the skull. It's there, and it's called foramen ovale because it's oval. And as we know, everyone that likes rugby, oval shapes always cause trouble. And the oval this way is fine, but the oval in the narrow bit can get constricted. And she phoned me and asked me when I'll be back from New York, because she needs to be declared dentally fit before she goes into hospital, because there's obviously risk of nerve damage and things like that, and that will affect all the teeth. Anyway, so I was sitting in New York, jet lagged, and I couldn't really stop thinking about her. And part of the lectures there was about, if you're going to treat someone with cosmetic dentistry, you have to make sure that if you're going to change their bite and their bite position, that they don't have any pain that's related in their face, or that you don't cause any pain. Because as I later found out more and more, is if you change the position of the teeth, then you could cause imbalances or imperfections in the bite position, which can cause pain. So this guy that were Jay Lerner, who gave us the lecture, he told us that he found out a way to easily relieve low-grade dental or facial pain by taking the teeth out of the equation. So if you remove the imbalances, even if it's temporary, you can check if the pain that the patient has before you do cosmetic dentistry is tooth related or something else. So he gave us, and I'll send it around, this stuff comes from America. And it's basically a little piece of plastic that you put some putty in, and I keep this in my surgery all the time. You put a little bit of putty in there, and then you place it on the front teeth of the patient, and when they try to bite, only the front teeth meet. And you leave the patient for 10 minutes sitting like that, and if their pain gets better, then you know that it's tooth related, or the teeth, because you've taken the teeth out of the equation. If their pain remains, then you look for something else. So what I did was, immediately I was thinking about this patient all the time. I thought, but I've never done that. I had 6 years at university. I've been through this patient with all her ups and downs, but I've never actually taken her bite position out of the equation. So immediately, as these things come around, and you can do it as well, I just put one of these in my pocket, and did the whole weekend, learned about how to do amazing veneers and smile makeovers and stuff like that. But when I landed on the Monday, I wasn't going to work because of jet lag, but I phoned the patient straight away and I said, listen, come in, I'll declare you dentally fit now. I know you've got surgery in a few days, but I just want to try something. And lo and behold, the miracle story, I placed a bit of putty in one of these jigs. I placed it on her front teeth, and I said, listen, just go and sit in the waiting room for 15 minutes. And I sat back on my computer, my surgery, and then about 10 minutes later, uninvited, the patient came into my room and said, it's a miracle. My pain is gone. So basically, I deprogrammed her facial muscles inadvertently, and the pain went away. So she ended up not having brain surgery.
So that putty goes on like.
Yeah, so I'll send these around. It goes inside the fitting surface, and the flat surface you'll see here goes against your lower teeth. So it sits on your upper teeth, and you can't bite in your back teeth.
Okay, so as soon as she did that, she didn't have.
Took about 5 minutes.
She still had the thingy, the brain thing.
She didn't, no.
She didn't. She didn't go. Oh wow.
Didn't have any surgery.
Yeah, that's amazing.
All right, so she was obviously very thankful, and she's still a patient of mine. We since rebuilt her teeth and placed implants where shouldn't have. Well, not shouldn't have, but did because of knowledge that I didn't have.
You don't know what you don't know.
No. You only know what you know. Right, so
But you obviously have to like dysfunction in the way. To place it. So when she came in, and you only placed one. So you just obviously knew from her bite like what looked a bit crooked, and you placed.
No, you just put it on your front teeth.
So none of the teeth.
yes.
Just the front one. So your bite and PMJ does occlusion. And your muscles are relaxed basically. So it's possibly it's not sometimes it's around your knee. So it would be
Correct. Yeah, and that patient as well, as soon as she yeah, just use a bit of play doh. Exactly. So yeah, and yeah, as soon as she took that out, as soon as the teeth came together again, the pain started again. Correct. Yes. Yeah, and I think over the last 10, 15 years, especially in the UK, more and more people have become aware of it in the dentistry. Because if you now we all know more about it. If you don't check it and something goes wrong, then you will tell your dentist, but listen, I've got this pain, you should know about it, why didn't you check it? So I think more and more now the standard operating procedures during a checkup, check the bite position and things like that. As we know, nerves are quite interesting. The trigeminal nerve, which causes this pain, does have this massive sensory function, and it goes 3 branches. It goes up to here, and it goes, on your maxilla and your mandible, and it's a huge sensory nerve, but it also has a motor element, and that motor element is the muscles of mastication. So if that nerve keeps being triggered by a motor function, of course the sensory nerve is going to start to become irritated, because we all, inherently the human body, and you will know it much more than me, wants to be balanced, and it functions better when it's balanced. So if you've got a imbalanced bite position, or if your teeth don't come together at the same time, then you will grind your teeth. Inadvertently, you will want to balance it out. So your brain will tell you, listen, there's an imbalance. You need to flatten whatever high spots there are now, get it out of the way, because I want to be balanced. My body wants to be balanced. And that will mean the muscles of mastication will keep contracting, and they will build a muscle memory, and they will keep contracting. And of course, so you eventually will break teeth, and your teeth will become flat. But most of the times it manifests as facial and headaches and those kind of things.
So really, the dental way of like just putting a mouth guard in is just alleviating the symptoms but not going to the cause. So if they change the bite position, then the person would stop grinding.
Yes. So,
Okay,
and if you look at a picture from inside someone's mouth, so these are muscles, and I've looked at all your pictures that we don't normally see on all these schematics. So this is the pterygoid muscles inside, and they also muscles of mastication. But this one, the medial pterygoid and the masseter and the temporalis, those big muscles all get controlled by the trigeminal nerve, and they contract, they close the mouth. They chew food. It's a primordial function. We have to bite, we have to protect ourselves, and we have to eat very hard food. So we need to have these strong muscles. But there's really only one small muscle that opens the mouth, and it's the lateral pterygoid that's green there. And it also gets controlled by the trigeminal nerve. And that small muscle fights against all these big ones all the time. So if you think you open your mouth just the same amount of times that you close your mouth, this muscle is actually always going to fatigue. So if that muscle fatigues by someone clenching and grinding their teeth all the time, then we go into a compensatory sort of cycle. And you guys know all about compensation in the rest of the body and how that affects. But that means now we have to use our platysmus and other very small muscles around our face to open our mouth. Now I have to almost strain to get the mouth open, and that's where facial and the headaches start as well. So you've got the trigeminal nerve that's irritated, so that causes pain, and now you've got all your facial and your platysmus muscles, small muscles that are not made to open your mouth, now opening your mouth, and that causes pain as well. So if you can switch off those muscles, not every one of us is going to have massive jaw surgery and orthodontics and equilibration of the bite position, but if we for 6 or 8 hours during the night can switch off those muscles and train them not to contract all the time, then we're going to alleviate the pain.
So when people I have to say, our niece is getting I can't remember what they call it, an overbite maybe she has?
Yeah.
So she's getting her whole mouth changed, but I guess there's no physio to retrain her muscles, because then her whole jaw is going to be completely different by the end of that could potentially cause pain, couldn't it? Because she has to retrain, her muscles technically have to retrain to how to bite a new bite.
Yes. I mean, and luckily in orthodontics, and that's why orthodontics are so good when you're growing, is that the muscles will move with the
And that's why it gets done.
and it happens quite slow, comparatively to other jaw manipulations. That's the muscles usually, but it doesn't matter how good the orthodontist is, there's always some kind of discrepancy in the bite. There are probably only 5% of people in the world who's got a equalized bite. Even after cosmetic surgery, after orthodontics, there's always going to be a discrepancy. And if you then have a psychological or a physiological tendency also to clench or grind your teeth, then those little discrepancies in your bite position is going to make it worse, and you will end up with some kind of parafunction, because your body will always want to be stable, it always want to be equilibrated, balanced. The muscles, this muscle and this muscle want to be in sync. Your body never wants one muscle to take over the other one, but it does happen.
So that's why dentists tell kids not to suck their thumb. Maybe one of the reasons.
Yeah, that's one of the reasons. Yeah. So I mean that's a very interesting other topic, and the narrowing of the airways when you suck your thumb and all that kind of stuff, because everything gets narrow, and the forces of sucking your thumb is also similar to orthodontic forces. So you actually move your teeth into the wrong position. Right. So this brings us switching off those muscles to contract. Comes to something a little bit more technical, and it's almost time to go to the pub, so I don't want to get your brains on a Friday work, but this and one of the earlier pictures of where I fix someone's teeth, you would see that the canines are always related to each other. You probably can't see it on that picture. This one is better. And the canines are specifically built to be in a position where they switch off nerves. So think about your canine tooth, the crown of the tooth is longer or of a tiger. But if you look on an X-ray as well, the roots of those canines are up here and down here. So it's got really long, strong roots in both. And after a lot of research, we found out those teeth are actually made not just to attack and tear meat and things like that, but they're actually there to protect the other teeth. So if you chew your food, you will most of the time during that procedure touch your canines. So what the canines does, and if you look at this picture as well, when the canines touch each other at a certain point where it's the highest, you can see that none of the other teeth touch. So the canines touch each other and all the other teeth are protected because they're not meeting. But also, we've learned that there's proprioception from that canine, both of them, when they touch, to the brain that says open the mouth, relax those muscles. So every time the canines touch, it says relax the jaw. And unfortunately, a lot of people's teeth look like this, where the canines have flattened, or orthodontically they're out of position, and it's what we call group function. So more of the back teeth will touch, and that is a massive trigger for clenching and grinding teeth. If your front teeth only, or your back teeth especially, only touch when you go sideways, you will tend to want to get them out of the way until you touch your canine, and that's the reason. Correct. Yeah. And there's a lot of people that when you give them a perfect smile, that say, "But I don't want long canines. I don't want to look like Dracula." And it's all driven by the cosmetic perception of what looks smile would look like. But it's not necessarily the function. But if you build a smile like this, where everything is in proportion, then the canines will blend in, but they will still have the same function. So if you, once you clench and grind the teeth in the back, again, triggers the muscles to overwork, the muscles that close the mouth, and there's no trigger to help those muscles to relax. Again, lateral pterygoid overworks, facial muscles have to help to open the mouth, and facial pain.
With that teachers that you showed the star, did you remove all her teeth and give her like veneers or
No, so she had, you show this picture here. So yeah, so one saving grace in her case, and and actually very technically, if she had full implants, we would not give her canine guidance. Yes, so we'd rather give a group function where the teeth sideways meet each other more to protect the other teeth. Right. In her case, we were lucky to be able to preserve her natural lower canines, which still got the protection with the proprioception, but she actually had pneumatization of the sinuses on the top here. So because she's got missing teeth for such a long time, her sinus, her antrum grew very close to the surface here. So she actually had 2 zygomatic implants where we placed titanium implants about that long from here into the zygomatic bone. So she had 4 of them on each side. These teeth were knackered in the back as well, so the implants go from the zygomatic bone to there, and then they have attachments that go into each of the implants. So she had in total 8 implants with specific attachments to those. But that's not the real reason why I wanted to show that. It's more about the cosmetic result afterwards. Right, so that's a little bit about canine guidance. And then over the years, because again, I said to John earlier as well, I mean, getting these patients out of pain, like that patient, 20 years ago when I was in New York, it doesn't pay the bills. The implants and the cosmetic work pay the bills, but this is the most satisfying. So, a lot of times instead of me reading about more cosmetic stuff, because I feel I'm okay at that now, I read more about the pain and about why people have pain. Because getting someone out of pain and they walk into your room and say, "Thank you very much, I've never felt so good in my life," it's much more rewarding than getting a check for someone that's got a cosmetic procedure and then they still come back and say, "But it's a little bit skew here, it's a little bit off here." It's a different type of satisfaction. But what we also learn is it's not just the canine guide, it's not just the canines that lift the teeth away from each other. It's actually the posterior teeth, the back teeth, the exclusion that switches off the chewing muscles. So even if you exclude the teeth further towards the front, from the canine forward, and the back teeth don't meet, it switches off those muscles, and all of a sudden those muscles over time stop wanting to contract all the time. Because if they contract during the night, every night for 6 or 8 hours, they will still want to do it during the day, and that is where the actual pain comes. So what we then over time developed, similar to the jig, is to actually have something that people can wear at night, will take away the back teeth from each other, protect the teeth. If example around what we developed. What we do now is we scan the patient dentist with 3D scanner, and we 3D print the models of the patient's teeth, and then make these nighttime devices. It's very similar in feel to what you will have in after orthodontics, but it's got a patented front part that's similar to the jig. All right, so these grey bits are someone's teeth, and when I show it around, you can immediately see why this patient have so much pain. And please give it back. I have to deliver this on Monday. But the first couple of lines that just had the jig now, so that I can see exactly what the bonding patterns are. So the first one we did was just the jig in the front and then a little bit towards the back. But over time we found that people get so addicted to it that they wear it all the time, every night. They can't go to sleep without it. That orthodontically over time the teeth will move. So if you only have an upper one and it's against the lower teeth, with that psychological clenching forces, people will in the end intrude the lower teeth and the ones in the front, and the back teeth, if they're not covered, will come down. So a patient will come after a couple of years of wearing this, and all of a sudden their bite will be even worse because the teeth have moved. So the reason we made these, and I say we, it's me and the lab Oral Creations that I work with, we ended up developing one that covers all the teeth all the way to the back. And a lot of the newer versions that you will see that come out will be full coverage of the teeth, and it works the same as the jig would. We put a bar on the lower so that there's a smooth surface. Yeah. Oops. Everyone's teeth are going like this at some degree. So we've got a smooth surface on the lower, smooth on the top, and when a patient tries to close their mouth, the back teeth don't touch. So we only have the proprioception on the front teeth, and we've got disclusion on the back teeth, which tells the jaw to relax. So as soon as any of the back teeth might touch, the patient will clench again. And usually after wearing this for a couple of weeks, the muscles relax. And we can then look at actually how we're going to restore this patient's teeth into the right position. There are many other night guards around there as well, but if you're looking at facial pain and jaw massacring muscle spasms and contraction, this is the best way that we found to do that. Right, I'll pass that around. So just one of the last things, and it's probably the topic that you guys wanted to hear about, is the TMJ. All right, so I don't know how much of TMJ pain guys that you treat, and that goes back to our friend the lateral pterygoid. Just want to show you that picture again. So and you can this is all plagiarized from the internet, by the way. This is not my pictures, but if you look at the lateral pterygoid, remember that is the muscle that gets fatigued to fight against all these masticary muscles. The insertion of the lateral pterygoid is on the capsule of the TMJ. All right, so and the natural muscle tone helps to keep the TMJ, the joint, temporomandibular joint, in the right position. So a lot of, not all, but a lot of TMJ pain comes from a fatigued lateral pterygoid. And again, people have been through surgery and through a lot of other manipulations of the TMJ unnecessary before it has, the other muscles have been deprogrammed with the device like that. I don't say, TMJ surgery is from the devil, but I would say that a lot of TMJ surgery gets done unnecessary. And Dave and I are big advocates of surgery is the last sort of resort. If a device like this, and I work with ENTs as well, if a device like this, after wearing it for a few days, A, cause pain, or B, make pain worse, then that's usually an indication that the TMJ, the disc has come off, or there is some kind of manipulation or intervention needed. But I would say 99 out of 100 times, if you deprogram the muscles, the joint actually goes back into the right position. So a lot of time, the lateral pterygoid doesn't function properly, or it's fatigued, and the whole joint gets pulled out of the position, and there's neurovascular tissue behind the joint that grows, and all of a sudden, every time the patient eats, they get pain. Once you deprogram the muscles, then it usually comes back into the position. Teeth have got a big influence on the position of the TMJ, and usually when they are in the wrong position, patients again will want to equilibrate their own bite position, and they will clench and grind their teeth to get discrepancies out of the way, and that pulls the TMJ out of the position. So nowadays, in our restorative clinic, we don't do any orthodontics, we don't do any implants or any big interventions of a patient's occlusion or bite before we haven't deprogrammed them with either a jig or one of those deprogramming devices. Yeah, and that's basically it. I can go on for another few hours if you want to, but maybe
When
we
you
should
say
go.
a jig, what do you...
The Lucia jig, the small one here.
Oh, that's called a jig,
Yeah.
sorry, yeah.
And people in real discomfort sometimes by just wearing that for 2 or 3 times a day for 10 minutes at a time actually help to deprogram the muscles. Because not everyone can tolerate the bigger versions as well. Although we always try to build them up to a position where they may do that.
Very clever. Do you make this one side?
Yeah.
Yeah.
So we've got a lab and we 3D print the models.
I have this every night in my mouth.
Yeah.
Got this with the jig.
I went, no. Jig face are fast, full mouth rehab, and just this because.
So do you find that sometimes just using this is enough for a patient? They don't need to go on to then need further surgery, they just use that and that's enough to address their pain. Is that common?
It is. In my clinic, a lot of people come because they want to have a perfect smile. So, but 9 out of 10 times they don't have the perfect smile because their function is wrong. Their teeth are worn and things like that. But if someone comes in with pain only, and of course, and unfortunately, in Weybridge, a lot of footballers' wives do suffer from a lot of pain. Headaches, stress, I don't know what about, but
Perfect teeth, they're stressing about the perfect teeth. To go with the perfect face and the perfect body.
but they would, for example, already have had veneers or cosmetic dental surgery, and they end up from having, you know, ugly teeth to beautiful teeth with pain. And yeah, they sometimes think that maybe the other dentist or someone has done you know, something wrong, but their friends, you know, at the tennis club or whatever said, no, I saw Eben and he sorted out my pain, and they come and see me, and they don't need any more cosmetic surgery, they just need those.
So where do you work out of, did you say?
In Weybridge.
In Weybridge.
Yeah.
Which?
Monument Hill.
Yeah. It's called Portmore Dental Practice.
Really? Oh yeah. I can picture it now.
So do they wear this all the time? Or
At
just
night.
Forever?
Yes, I planted that seed initially.
So basically that's,
Yes.
you've invested in that now, you've
Yes.
got that now as your livelihood.
Yeah.
Yeah.
And you know, a lot of patients don't want to sleep without after they feel that it's, you know, relax their jaw and relieve the pain, and they
It's a
want
good
to.
pain if you stop.
So
Week without it, I'm in agony again. Headaches and stuff come back. So I've been sleeping with this for 10 years.
Yeah.
it's just came to
12
put thing in, yeah.
Yeah, night time.
Yeah.
12 years.
Yeah.
Yeah.
It's because I was a sports person and my headaches came from sporting and clenching.
Yeah.
And I went brain scans and goodness knows what else by the time they figured out why I was having headaches at age 18. So then I went to a dentist and he just tested all my muscles in my mouth, gave me the jig 13 years ago, 14 years ago now, and then relieved my pain and I was sold.
Perfect.
So I had full mouth rehab actually, it just didn't go well because unfortunately my uncle has got to dementia by the time we finished, so I don't think he's finished everything right.
Wow.
Yeah, the story, I had implants and everything, so
Yeah.
yeah, and pain, but my pain is... Yeah, I don't know, I'm coming for second opinion, because my dentist is not.
It's up and in fire.
No, I mean, because that had that type of, the full one for
Yes.
13 years, because my
Very good.
dentist was under Dawson's Academy, so they'd done, one was South African, the other one was from Britain, but they didn't believe the British type of teaching because they just went abroad to learn,
Yeah.
like we did with the Canadian style of type of physio, because it just wasn't good enough. But it's recognised.
Yeah.
I was lucky
So,
enough.
so Dawson Academy, a guy called P. Dawson,
Yeah.
you know, he's already passed away, but he taught into his 80s, and he was, you know, he was a big sort of promoter of this kind of treatment, and he started teaching it in the 50s, and a lot of other dental professionals, and yeah, that's one of the dentist's favorite hobbies, is to criticize his colleagues. He has actually shot him down over the years, but all the patients and his followers were like evangelical about it. But there was, you know, he's American, there was so much politics in America, there was certain groups, almost like religions, of how to treat dental patients. Not enough patients got patient who I got out of pain was you know, I thought initially it was witchcraft, because you know, how it worked was it, but the more and more people then get referred to. I mean, clenching and grinding and facial pain is a lot more complex than that. I mean, we can all go on a course for 2 weeks and we still won't know enough injectables, and I masseter and temporalis muscles every week, and for various reasons, if they can't tolerate that because of a gag reflex or as an adjunct to that treatment initially to help to soften the muscles. Yeah, and there are other treatments as well that's maybe permanent or semi-permanent, but at the end of the day, if you look at and you understand how the nerves work, then it's actually pretty simple. can switch off those muscles. So they're only made to chew food. They're not made to go to the gym every night. Then we can help a lot of people. And with physiotherapy and Dave and I've been talking about that a lot. I mean, as soon as, and it might come from something else, as another compensatory thing, but as soon as these facial muscles and the masculine muscles all get into a tizzy from contracting all the time, the more it affects the rest of the neck and the shoulders, and you want to open your mouth or close your mouth, and your breathings and everything starts getting tight, and then sequence can become quite a challenge. But I always use the KIP. It stands for keep it simple, keep it. And if you just go one stage at a time and look at it. Yeah, so I would definitely look at the masseter muscles. So have something to compare. I've got a really tight masseter muscle. That's I do a lot of speaking, but there will always be a trigger point of pain in those muscles. So if you palpate the temporalis and the masseter, and you press somewhere and the patient goes, or they hit you, or they run out of the door, then there's something going on with their bite. And guidance, yes. Yeah. So I mean, there are many ways, and if you guys are allowed to inspect the mouth, then I would love to have another session like this and actually teach you how to look for things in the teeth, and you can actually sort of, if you're really careful, palpate the medial and the lateral pterygoid as well. But another thing to look for is to ask a patient to bite on their back teeth and then slide their jaw together by keeping the teeth together. So if a patient bites down and he can slide his jaw to the side, and I've got canine guidance, I go into the canine very freely, then that's great. But if you ask a patient to bite down and then to slide the jaw around and they go like, I can't, then you know that they're locked in. And usually group function in the back, and that is definitely another sign, and then you just send them to me.
So do you do intraoral as well?
Yeah.
So I do as well intraoral, so I love kind of everything, sort of cranial, like headaches and the fascia lines, then, because like the amount of people, like we fix headaches like from just releasing around thorax, and the tension just drops, and then you can go up, like adjusting the sphenoid, and then the trigeminal pain goes, because the ovale exit just feels a bit less tension,
Yeah.
because the sphenoid isn't sitting like this. So I think like it would be good to have like a kind of practical session, is it, on it, because like like I feel like I'm on my own here, but now you here, so I'm just like
patient who I could just see her jaw as she's talking, like I was doing whatever, I thought she was neck problem, and I could just see, like, as she's talking to me, her mouth is just moving so asymmetrically. So I have to say, I'm like, Vida, do you want her? As Emma, the twin, the girl with twins, and I just like, and then Vida's just because I don't feel as comfortable with all of that, but it's just so weird, when you first notice, you're like, jeepers me, but probably looking at her I never really noticed, but as soon as she's upside down and I only looking at her mouth, it was like so asymmetrical.
Yeah, because I mean it will be very important for me and any other dentists as well to see what you guys look for. And now you examine the mouth and intraoral and stuff like that, because you guys obviously have got a deeper look at how these things are connected to the rest of the body. I just know that if I relax these muscles, then they're out of pain, or sometimes something else relaxes and they feel better. But there's obviously from your guys sometimes there's a bigger connection as well. So
like the teeth as a part of the cranial region driver.
Yeah, good.
Teeth driver.
Yeah.
Yeah, TMJ driving.
So what? So if you. If you went right, if you haven't got it and you want to get it, what would it, is there a process that something from non-radical to radical to get it?
yes, I mean the non-radical ways are, if the patient qualifies, are actually quite satisfying as well, and it's similar to just giving them a jig, and there's actually in the invisible areas, if necessary, of the canine, building up a little ramp with composite filling, and it's not in the way when a patient dies down, but it's almost it's a little bit longer without making them look like Dracula, so that when they do slide their teeth, that the canines actually touch each other, and as soon as that happens, as soon as the back teeth disclude, then you just see that light going on, and people feel very comfortable, because for years they might have been, the canines been either out of position or worn down, that they've been so locked in for so long that they don't know any better, because every time they try to go into the canines, all the other teeth are touching as well, so they feel like they're in lock. But as soon as you make that longer, then that feels better, it just opens the. So that's a simple way. If the canines are so far apart, that you can't just build something up, you can, and that's where we came to the anterior or the front disclusion. You can build it onto another tooth. I wouldn't just recommend that to any dentist, but if you know where that corner is, and you can build up another tooth, again, maybe hidden behind the teeth, they can have a ramp on another tooth. Orthodontics is a bit more invasive, so if the canine is not in the right position and there's no way you can build it up, and then usually they've got a cosmetic issue as well, then we use, luckily these days I use only clear aligners, Invisalign type treatments to move the teeth into a better position, or you can move them so close that then just a little bit of bonding or cosmetic work can get it into the right position. And then all the other more gory stuff as well, jaw repositioning, and we work with surgeons that people with micrognati, where they've got a very small lower jaw, to do LaFour type operations to actually get and one of the criteria for doing those surgeries, apart from the way, is actually to get anterior or canine guidance to the teeth. So a lot of people, very small lower jaw, the deep overbite or overjet, as we call it, do suffer from facial pain as well, because the teeth are so far away and the airline is blocked as well. So
I think we've talked before. If someone's had a bad filling previously, effectively if someone built up too much, then that sticks everything over to out of kilter and
drop it over to the other side. So in the noughties, for a few, sort of 2009, 10, there were a few guys when in the UK this became a big thing. Had a day course or a day lecture and a half day hands-on, where they taught people how to build up the canines to get that, and then 6 months later you had so many people in pain, because you can't really just learn it in a day. And then on Monday starts, okay, I'll just put composite on everyone's canines and I'll save the world, and then actually making the whole situation worse. But good diagnosis and treatment planning, like you guys know, is the name of the game.
Just to give us a little bit of an idea, if someone was going to have go through the process of getting to a mouth guard and that sort of stuff, what sort of price situation is that as such?
Yeah, I mean,
Just if you get a client,
you,
you think this looks like
yeah,
this,
so if you have the full treatment plan and diagnosis, you know, if they've had a proper checkup already and stuff like that, it's probably about £450.
Okay.
That includes 3 visits, so records, fitting, and follow up. But usually, when a patient comes to that, they've had a full diagnosis with me.
Yeah.
I wouldn't just give that to a patient if they come from their other dentist, even if he's my best mate. He's a very good dentist, and he said, well, my dentist looked at my teeth and everything's fine, but he said you should have one of them. I'll still go for my full diagnosis, and then that might be £100 or so for 45 minutes, just making sure that that's appropriate for them.
Yeah, perfect.
Yeah.
I think it's always it's a nice one because obviously, as soon as you mention teeth, people think, well, that sounds like it's going to be expensive. So, but if you can say to them, look, it's not going to cost you much more than £400 or £500, that's much more of a they go, oh, okay, that sounds sensible rather than.
Yes, and all the research and development and all those kind of stuff, you can't actually charge enough to get someone out of pain.
Yeah.
People pay thousands and thousands for orthodontics and surgery and stuff like that, and they'll still not be cured. But it's more the satisfaction. And when you have a patient that's deprogrammed and out of pain, then you can say, what else do you want? So yes, my checkbook. But if you do something and it's not right for their bite, or you cause them more discomfort, or you don't fix it, then it's like, where's the trust gone? Because there's someone attached to the teeth, so it's definitely not a money maker or a practice builder in that sense. But it works.
Wonderful.
Great, thank you.
Thanks so much.
Thank you.
No worries.
I think we'll be booking in.